So, whilst hot flushes are considered the hallmark symptom of the menopause and occur in about 80% of women, what is less known is that musculoskeletal pain actually occurs in around 70% of women, and in some cultures is the most common symptom of menopause. Now, last year there was a publication coining the term the musculoskeletal syndrome of menopause, and whilst this has not reached universal acceptance as terminology, what it does is highlights the number of musculoskeletal conditions that are associated with the menopause transition to help clinicians and patients alike be aware that these things occur in clusters and are associated with changes in hormone levels of menopause. Last month, there has been or in fact this month, a publication looking at the effect of meta-analysis and systematic review looking at the effect of hormone replacement therapy on musculoskeletal pain. So these two papers are relatively new, and this is an area of increased awareness. Now, there is quite a lot of research in these areas, and a lot of it is not is having controversial or conflicting results. So now the conditions we're talking about are an increasing association with menopause are arthritis, both osteoarthritis and rheumatoid arthritis, adhesive capsulitis or frozen shoulder, tendinopathy, for example, trochanteric pain syndrome, which is often described as bursitis on the outside of hips, sarcopenia or loss of muscle mass, and generalized musculoskeletal pain and osteoporosis. So these are all elements of the musculoskeletal condition that are impacted at menopause, some more clearly related to hormones than others. Now, in osteoarthritis, the incidence in women rises after menopause, and it's much more common in women than menopause. It affects mostly the knees, the hips, and the hand. Now, there are animal models describing plausible mechanisms of the role of estrogen and cartilage. If in an animal model, if we create a surgical menopause by removing their ovaries, which is not what humans experience, but if we do that, then they get accelerated cartilage loss due to the low estrogen. There are various observational studies looking at the role of menopause hormone therapy users and osteoarthritis, and these are conflicting. So some studies show that women who are on HRT or MHT are more likely to have joint replacement surgery. Some studies show that they are less likely to have joint replacement surgery. Some studies show they're more likely to have X-ray evidence of arthritis, and some studies show they're less likely to have X-ray evidence of osteoarthritis. But there are fundamental flaws in terminology, in defining what sort of menopause hormone therapy is used, the length of use of menopause hormone therapy, and there's also confounding variables, in particular metabolic syndrome and obesity across these papers. So we can't make any broad conclusions except to say that arthritis is definitely more common in women after the menopause. There's also, when we look at rheumatoid arthritis, which is an autoimmune condition, there is a spike in diagnosis close to the last menstrual period. Indeed, about women after the menopause are twice as likely to be diagnosed with rheumatoid arthritis, and women who have an early menopause, so that's before the age of 45, are 3 times more likely than premenopause women to be diagnosed with rheumatoid arthritis. And of course, estrogen is thought to have anti-inflammatory and immune suppressive role. So frozen shoulder is definitely more common in women after menopause. In animal models, both the hormone relaxin, which is a pregnancy-related hormone, and estradiol reduce capsular fibrosis in models of frozen shoulder. There's very little data on women using MHT, but one observational study showed that women were half as likely to be diagnosed with frozen shoulder. This paper was only presented at a conference, so it's not even in publication. So very little data looking at adhesive capsulitis, the frozen shoulder. Now, the old hip bursitis, so on the outside of your hips when you get pain with stairs, walking, side lying, this is called greater trochanteric pain syndrome, by definition, is often impact changes in the tendons as well as the associated bursa that sits beside them. Estrogen certainly has an impact on tendon strength and inflammation. There is a single randomized control study by Jill Cook, published. Jill Cook, one of the researchers, she's a Victorian researcher, showing that women with this condition improved with any exercise and time, and MHT didn't make a big difference. The only group that did better on MHT were women with a low BMI, and that wasn't a huge difference. So this is the only randomized control trial looking at the role of hormone therapy on trochanteric pain syndrome, and it's not very impressive as a positive impact. Now, muscle mass, what women often talk about losing their muscle at menopause, but both men and women lose muscle as they age. And the biggest factor for reducing sarcopenia is strength training. So the role of aging is probably more important than the role of hormones. The role of estrogen and testosterone is yet to be fully understood. Certainly, if women take supraphysiological levels of testosterone, then they can improve their muscle mass and definitely speed and strength outcomes. But there is the risk of unwanted side effects such as facial hair, acne, hair loss. And of course, this is why testosterone is banned for women in Olympic sports or in many sports. Both men and women respond to resistance training with dietary support, specifically protein intake, and protein intake may need to be higher than the recommended daily intake of I think it's 0.8, probably 1.2 to 1.6 grams per kilogram per day is probably better for exercising women to maintain muscle mass. Of course, you can eat as much protein as you want, but if you don't push those muscles to work harder and challenge them, then you won't build muscle. Protein doesn't automatically end up in muscles because you eat it. The role of menopause hormone therapy is equivocal. Some studies show that it improves muscle strength in randomized controlled trials. Other studies show that it does not. So there is also a bit of controversy around what type of weights are important for women in preventing sarcopenia. There is quite popular to be told that women need to push low reps and heavy weights, and this is not true. Women just need to work to fatigue. So if you push lighter weights, more reps to fatigue, you will still experience muscle hypertrophy and increased muscle mass. So both those things work, just that higher reps of lower weights are less likely to result in injury and therefore more likely to be sustainable. So generalized musculoskeletal pain is super common, 50 to 90% prevalence, higher in some cultures than others. For example, in Japanese women, the most common complaint of menopause is shoulder stiffness. This is the pain that's soreness in your fingers and joints generally, warms up a little bit. It's quite inflammatory in nature, much more common in perimenopause and postmenopausal women compared to premenopause. It's also related to smoking and higher elevated BMI. Now, generalized pain conditions are also made worse when people are not sleeping well, when they are depressed or anxious, and their mood is off. And so all of these things happen at menopause as well. So there are other confounding factors for generalized musculoskeletal pain, not just the direct impact of estrogen on musculoskeletal pain. I must say that the data on the role of MHT in musculoskeletal pain in general is not strong as a benefit. And again, it's mixed results. But in my personal experience, anecdotally, this is one of the things, generalized aches and pains is one of the things that does respond quite nicely, particularly around postmenopause, to menopause hormone therapy. So osteoporosis is a really important factor. It is not a symptom until you break something. So osteoporosis is the loss of bone mineral and weakened bone. Now, estrogen is a strong protector of bone. It reduces, bone is a dynamic tissue. It's always eating itself up and laying down new bone in response to things, and it responds to load so exercise and impact, and it responds to hormones. So estrogen is a strong gives strong messages to bone to prevent resorption. Now, when we go just before the menopause and afterwards, trabecular bone, so bone not of the long bones, but the spine and the hip and the wrists, declines up to 20%. Menopause hormone therapy can increase bone density of the spine by 5 to 7% and reduces fracture risk. It's important that because overall osteoporotic fractures are reduced by 25%, hip and spine fractures are reduced by a third. Now, hip fractures are quite devastating. So if a woman has a hip fracture, it has something like a 20% 1-year mortality. So many women who survive don't go back to the living independently or the standard or quality of life that they had prior to their hip fracture. So these are really important things to prevent. And we don't know we have osteoporosis unless we have a fractured bone, and check our bone density. So hormone therapy has shown to be effective in preventing osteoporosis and treating osteoporosis in conjunction with other interventions such as nutritional building blocks, so your calcium, vitamin D, magnesium, vitamin K, and training. So tugging at bones and impacting bones. High impact stuff like skipping, pushing heavy weights is important. The Lift More trial is research that was completed in Queensland, Australia, and it showed that women with postmenopausal women with osteoporosis experienced increased bone density with doing certain exercises under supervision. So that was a push, a pull, and an up down. So a squat, a deadlift, an overhead, I think it was an overhead press and or a chest press, and a drop from a chin up height for impact. Quite heavy weights, and this has resulted in a program called Enero, which is licensed to exercise physiologists and physios to deliver these programs under supervision. Important to understand that lifting very heavy weights does put people at risk of injury, and it needs to be supervised. But it's not the only way to improve bone density. So lifting weights at any point will be helpful. This is not the only way to do it. This is not the only form. So I think it's important that we recap and remember that physical activity is crucial to health. Being physically active reduces the risk of many chronic diseases, including mental health problems, cancer, stroke, cardiovascular disease, diabetes, dementia. It's really important that women stay active. And musculoskeletal symptoms related to the menopause transition are varied, and they can certainly impact someone's ability to be physically active, and therefore they are important. We should be aware that there are many different treatment options for these. All the standard treatments apply, and hormone therapy has not currently been shown to be effective in MSK conditions, despite the large amount of data. But this is requiring further research, of course, and we are yet to see some good studies that actually say whether MHT is helpful or not. So we're waiting on that one. So I hope that is kind of helpful, and I wanted to share those two new very important papers with you.